All right, so welcome to this session. We are going to be talking about cannabis in older adults, and I'm here to introduce the speaker. My name is Kari Everson. I am a board member for MAGIC and on the conference planning committee, so we're happy that you're here and welcome. Dr. Emily Eskew is our first speaker, and she is a geriatrician seeing patients in outpatient nursing home, assisted living, and home settings. She attended medical school at the University of Tennessee and completed residency and fellowships at the University of Chicago. She is board certified in internal medicine, geriatrics, hospice, and palliative medicine. Dr. Eskew is currently a faculty geriatrician at Hennepin Healthcare and assistant professor at the University of Minnesota. Co-presenting with Emily today is Robert Rohde. He is a partner and practices in the areas of health law, civil litigation, employment law, and administrative law. Rob has a special emphasis on elder care providers, including nursing homes, assisted livings, home health, rehab, adult day, hospice, and housing. And he represents and advises clients on issues including regulatory and legal compliance, surveys, complaint investigations, et cetera, et cetera, et cetera. So if you'll join me in welcoming Rob and Emily.
So quickly, our objectives. And then disclosures. I don't have any financial disclosures here, but because of the nature of this, all products I'm going to be talking about are federally illegal, so not FDA approved, so all of this is off-label. And information is changing rapidly, even within the last few weeks. So this is as up-to-date as I could be for today, but this is changing on a week-to-week basis.
And there's a lawyer here, so there are disclaimers in addition to the disclosures, right? So the first one is, hopefully, we're going to be sharing some information, but if you have questions or you want to ask anything, please do. I mean, this is the opportunity to do it. I think we have a much better product of spending our time together when we make it a conversation versus just listening to information, right? Having said that, though, this goes right into the disclaimers. One is, if you ask me a question, I'll answer it the best that I can. I always got my little lawyer hat on my head. My kids don't always like that, but I'm going to give you legal information in my response. It's not legal advice, because if I was giving you legal advice, number one, I'd probably have a million follow-up questions to get that nailed down, and secondly, I'd be giving you legal advice, employing the privilege that we would have as attorney-client. So it's not legal advice, it's legal information. Second piece goes into, if you do have a question or if you want to share an experience, we're working with the understanding it's hypothetical. And the reason for that is we would never, ever, ever share protected health information outside of our agency without consent, right? So working with those two disclaimers and those understandings, let's take it away.
So where this session started is back in July, there was a new law passed that Minnesotans can buy edibles and beverages containing up to 5 milligrams of THC per serving. And I was asking my colleagues, how comfortable do you feel talking to patients and answering questions about THC and counseling about THC? And I got a lot of, I don't know. And then talking through some of the questions, a lot of things came up with what are the legal implications, especially for our patients that are in facilities that are taking federal money with dealing with a substance that is state legal but federally illegal. So we're doing this split session to try to answer those questions. So I'm going to be covering some of the clinical sides I think will help you be able to answer some of the questions that people will be presenting, and then some of the questions that the facilities you're working with will have too. And this is in the setting, I think for a long time, geriatrics kind of said, well, most of our patients aren't doing this, but that's not true. That over the past 50 years, but especially the past 20 years, now 38 states and Canada have legalized cannabis in some way. Support for legalization has increased greatly in the US. And use among older adults has also increased quite a bit. The most recent I could find was 4.2% of older adults in 2018 had said they had used cannabis that year. And the majority, especially of older adults that are going to dispensaries, even recreational dispensaries, are really going looking for a medical use, so trying to treat some symptom, pain, sleep, anxiety. This study from the UC San Diego supported that of their patients in their senior care clinic, about a quarter had tried cannabis at some point. And of the people that were regularly using, more than 80% were using for some kind of medical use. And you can see here, pain, sleep, anxiety were common of what people were looking for treating with this. And about 3/4 said it was somewhat or extremely helpful. The one caveat I will say is, and there's a couple things with survey information, anytime you're talking about surveys of active users, these are already people who have chosen that this works for them. And so you're kind of taking off the top who thought this helped. But another thing is that less than half of those older adults had talked with their healthcare providers about the fact they were using this. So you'll hear cannabis and marijuana and THC and CBD, and what does all that mean? So when we're talking about cannabis, it's a group term for all products derived from the cannabis sativa plant. And traditionally, what was thought as marijuana is cannabis sativa with more than 0.3% THC, and things were classified as hemp if they were less than 0.3 THC, but it's the same plant, just different strains of that plant. I put marijuana in quotes because in the medical community, there's been a real push to move away from using marijuana because of concern for xenophobic and racial implications with that word. And so we're gonna be talking about cannabis. And in the Minnesota medical cannabis, we use medical cannabis in most of what you'll see. A cannabinoid is any kind of biologically active compound that can interact with the CB1 or CB2 receptor. So we have cannabinoid receptors in our CNS and in our periphery and on immune cells that our endocannabinoid system, we already have substances in our body that have been interacting with these receptors. There's also more than 140 substances in a cannabis plant that interacts with these receptors. And then our synthetic drugs, so dronabinol and Epidiolex are both FDA-approved drugs. Dronabinol for like chemo-induced nausea and HIV-associated wasting and weight loss. Epidiolex is a CBD analog that's approved for certain kinds of pediatric epilepsy. And then a lot of times when we're talking about cannabis or cannabis in general, we're usually talking about THC and specifically delta-9 THC. It's considered the most, we think it's the main psychoactive cannabinoid in the cannabis plant and is responsible for the majority of the medical effects and side effects. So it interacts with those CB1 and CB2 receptors to work on the release of acetylcholine, glutamate, dopamine, and has downstream effects in things like GABA and opioid receptor signaling. So these should be recognizable. These are pathways that a lot of our pharmacologics work on already. THC is considered a Schedule I controlled substance for now. I put that asterisk there because within the last month, President Biden issued a call to re-examine the scheduling, because with it being a Schedule I right now, it can only be studied as a drug of abuse and can't be studied for medical reasons. That would also have implications as far as legalization. CBD is cannabidiol, and it's thought to be not psychoactive, but possibly analgesic and anti-inflammatory. There's very limited data out there on efficacy, but it's considered safer than THC. It is not regulated by the Controlled Substance Act, so this is available over the counter, at the mall, over the internet. There was a NASM report back in 2017 looking at what are possible medical uses, and they concluded that there was substantial evidence for efficacy in pain, chemo-induced nausea and spasticity, as well as sleep disturbance, and then some limited evidence for appetite, anxiety, PTSD, and then evidence that it may be ineffective for things like symptoms of dementia, glaucoma. We'll talk a little bit more about that. I say side effects, but I would just say kind of the general effects. So I sort of divided these into some positive effects. So usually our medical aim is not to induce euphoria, which is that sense of well-being or high, but it can. But medically, some of the positive effects that THC can have is improving appetite, nausea, pain, sleep, and spasticity and multiple sclerosis. But on the negative side, it can also cause psychosis, impaired memory, cognition, judgment, and reduced motor function. So I think about confusion and falls in my patients. How much of these effects that people get depends on the dose, the route, meaning is it ingested or inhaled, and then the ratio of THC to CBD of the product that they're using. So on the short term, there is the risk of impaired short-term memory, motor coordination, and judgment, and an increased risk in car accidents. But I'd say that 2 times increase, compare that to an 8 times increase in use when people are using alcohol. And there's several studies that have showed in states that have legalized, there has been increased ER visits related to THC use. With long-term use, there is an increased risk of anxiety, depression, and psychosis. And it has been shown in young adults up to about age 26 that chronic use can cause structural brain changes. So I think there's long-term questions that we'd have about this. THC is not considered something that you can fatally overdose from. But one thing to know is there is a withdrawal syndrome. So for people who have been chronically using cannabis or THC and now are in a setting that they're not allowed to, they could go through a withdrawal syndrome. So who would I absolutely say I don't think should consider this? People with unstable cardiovascular disease. Use of THC can raise the heart rate and raise the blood pressure, and there have been case reports of MI and heart attack affiliated with THC use. Also, people with significant psychiatric disease or psychosis, because of that risk, that we destabilize them. I also talk with patients that there is a risk of chronic bronchitis or lung damage with inhaled products. If we take too much, there can be acute intoxication that can be uncomfortable. Not considered fatal, but uncomfortable. Cannabis hyperemesis syndrome is something that's seen with high-dose, long-term use and is intractable vomiting that improves when you stop the cannabis, and also with hot showers, so if you've ever heard that. Driving while intoxicated is still illegal, even if this is legal, so same with alcohol. If you are under the effects, you should not be using a car. And then this is still not federally legal. So they can't take it on an airplane. They shouldn't take it across state lines. Even having a medical card or being medically approved does not change that fact. There are some important drug-drug interactions, and a really big one I'd want to alert you to is warfarin. It can raise the INR, and so if your patient is using a cannabis product, you'll want to monitor that closely. Other things that I see in my practice, olanzapine, fluoxetine, amiodarone, can have some changes because of the CYP metabolism of both THC and CBD. And then I also talk to people that it is sedating. And so even if there's not a direct interaction, if they're on other sedating medications, this could just make them more, more sleepy, more liable to fall or be confused. So if your patient would still like to try this, and this is really, I think about this with these edibles that are out there, because we'll talk about the Minnesota Medical Cannabis Program. This isn't something that we prescribe. But if the edibles are out there, and we said 5 milligram pieces are what they're going to be, a usual starting dose for THC is generally 2.5 to 5. So that's actually half of one of those edibles. And if you have a patient who's very frail, I'd even start lower, maybe a quarter. Just like everything in geriatrics, start low and go slow is going to be the right way to approach this. So when I'm advising a patient, I'm saying maybe not taking that full edible. Another thing you need to know is that this is the law in Minnesota, but other states do not have that 5 milligram edible. So they really need to look at what's on that package, because there have been edibles that have up to 20 milligrams at a time. And so I used to tell patients, if you're getting something from your niece in Colorado, you may need the foot of the gummy bear, not the whole edible, because of the dosing. Probably not with these edibles, but with the medicinal products. They can control the THC to CBD ratio, and it's usually recommended that we start with a 50-50 ratio, because the higher the THC, the more of those psychoactive side effects people are going to have. The other thing I think it's really important patients know is the difference between inhaling and ingesting. So when someone inhales, either through an inhaler or smoking a joint, it hits pretty fast, so it doesn't have to, it doesn't have to go through first pass metabolism, so it peaks within 15 to 30 minutes. Someone will feel the effects, and they can feel those effects with as little as 2 or 3 milligrams, which is 1 or 2 puffs on an inhaler or a joint, and then usually last up to about 4 hours. But that's going to be very different with these edibles. So the edibles have to be absorbed and then are metabolized in the liver to this 11-hydroxy THC metabolite that's actually more psychoactive and longer lasting. So with these edibles, expect onset in 30 minutes to up to 3 hours, and then it can stick around for 12 hours. And I think it's important people know this, because if they take an edible and don't feel anything in that first hour, they shouldn't take another one, because they may overdose, they may get too high and then feel really odd. And I think that's where people are winding up in the ER. And so I think it's really important they know that with these over-the-counter products. So what does intoxication look like? Generally happens at doses over 7.5, but can be nausea, vomiting, increased heart rate, increased respiratory rate. It can raise or lower the blood pressure. We know about the red eyes and dry mouth. But on the more serious, it can be delirium, anxiety, or panic. And you can get neurologic symptoms like myoclonus, nystagmus, trouble walking, slurred speech. Most times when people take a little too much, it's very mild. They may have a dysphoric reaction where they just don't like the way they feel unwell or uneasy. And in that case, management is decreasing stimulation, reassuring them, putting them in a dark room, letting them sleep it off. A short-acting benzodiazepine might be helpful if they're quite anxious. If they're having a severe reaction, psychosis, agitation, especially if they're in a facility, that might be, and we don't know exactly what they took, that would be a time to consider medical evaluation, because could they have a medical emergency like an MI happening? Could there be another substance in whatever they used? And is this severe enough that they might need medical sedation until the effect of that wears off? The Minnesota Medical Cannabis Program, any licensed physician, APRN, or PA can become registered through the website in order to certify patients that they would meet criteria for medical cannabis. And so if you're not familiar with this, you do not prescribe, because when we prescribe something, we're giving them exactly what we want them to take, what dose, how often. That's not quite how this works. That what your role in this is that you have an ongoing relationship with the patient, that you think that they do have one of the conditions that Minnesota approves, and that you think that cannabis is reasonable in their treatment plan. The medical cannabis program now has multiple different routes of how this. It used to just be capsules, tinctures, sprays, and inhalers, and in the past couple of years, they've added edibles, smokable plant, and topicals. So here, it's quite a long list of medical diagnoses. Some of the pluses, I think, of our program is that when someone is certified by a doctor, they then go to the dispensary and meet with a pharmacist who can help they will talk to them about what their symptoms are, and can guide initiation and titration. So a lot of my patients have gotten like a starter pack where they start with a low dose and work their way up. But access is a major issue. It's about $200. It is $200 to get certified, and then you have to buy the product themselves, which can be $75 to $250 per product. And then transportation and getting to the dispensary, so that the patient has to be able to get to the dispensary or have a designated caregiver that you put on the initial certification that goes. And then they have to yearly renew and yearly pay that $200. So I think cost and access are a big issue that these new products help circumvent, and will open this up to people that were not able to get because of that. And I would say my one other thing that I think is a little low is the communication with providers is lacking. I've had patients that are going to the dispensaries regularly, but I don't know what they're using. They can tell me how it's working, but I don't really know the details. What I'll get is, I'm using this orange capsule and it's helping this, but I don't really know what that is. So what evidence is there that this works? Like we said, it's best for chronic pain, chemo, nausea, and MS-related spasticity, but there are more studies happening now. The downside is they're generally small and very heterogeneous as far as what dose, what kind of product, and what kind of route. So unlike some of our drug studies where I know this was 20 milligrams of Prozac, this could be on a very different product than what your patient's holding. The other thing to know is there's been multiple studies between the US and UK of discrepancies between the listed amount of THC that's in a product and what is actually tested in that product. So that also goes, since this is not FDA approved and is not regulated in that way, there's not a guarantee that what is on the product, the package, is exactly what's in the product. And like I said, it's just difficult to study right now because as a Schedule I substance, it can only be studied as a drug of abuse. But in the past couple years, there have been a couple studies in major journals, both in the US and the UK, supporting the use of THC and saying that this is probably not a first line, but there's good enough evidence that especially for chronic pain that we know is so hard to treat, that if standard of care isn't working, that there may be a small improvement with cannabis. With Alzheimer's, not so much. So there was a Cochrane review last year that found little or no clinically important effect on cognition or behaviors. So I went to the MDH website to see, so why is this on our list? And what they cited was 2 small observational studies that showed decreased agitation, but of their randomized trials, only 1 showed a positive effect. There's currently a study ongoing with dronabinol looking at agitation that should be completed next year that may give us a signal towards could THC be helpful. Parkinson's is not one of the certifiable conditions in Minnesota, but there's a lot of interest in it because of the benefit in MS. There have been several small trials that are very mixed as far as improvement. The surveys of patients who use it do feel like it's helpful, though. Glaucoma is interesting because there is actually CB1 and CB2 receptors in multiple structures in the eye, and both oral and inhaled THC have shown that it can lower intraocular pressure. The issue is to actually get that lowering, the doses needed is 10 to 20 milligrams about every 4 hours, which is more than what people usually can tolerate. So really, I'd say as a therapeutic, probably can't count on THC actually lowering your intraocular pressure. Question I get a lot is, so what about CBD? And in that UCSD study, almost half of patients using a THC product or using a cannabis product were using CBD. CBD is considered non-intoxicating and not restricted under current laws, and theoretically, some of the anti-inflammatory properties might be helpful for pain. There's even less study data about CBD and really mixed results. But it's generally considered safer, so if someone wanted to try, this may have less side effects. One thing to know is a lot of the CBD products do have some THC in them, and the more efficacious ones are probably the ones with some THC, that a blended product is probably gonna be more efficacious. So they may still be exposed to some of those side effects. And then just from a safety standpoint, one thing with the FDA-approved CBD drug is that there have been liver toxicity shown. So if someone's wanting to use CBD and has serious liver disease, I would talk to them about those risks. And then another question is topicals. Is theoretically a cannabinoid, either THC or CBD, there are receptors in the skin that they could interact with, but if you know anything about topical medications, there's so many factors of how to find an efficacious product. So there's molecular factors of how big and how lipophilic the molecule you're trying to get into the skin is, what the concentration of it is, and what kind of vehicle you're using, whether you're on intact or broken skin, because things are going to absorb more on broken skin. And so it's scientifically plausible, but there was actually a NASM report on topicals a couple of years ago that said insufficient evidence for or against. I go forward. So kind of wrapping up the clinical side, I think it's reasonable to consider 5-6 years ago, I would say, well, I just don't have any data. I think there is data now that says it's reasonable as a not first line, but possible treatment for chronic pain, cancer-related nausea, and spasticity. If someone wants to try this, talking about that one edible may not be an actual serving, or one serving may not be a starting dose, and so maybe starting at a quarter to a half, and that if you're going to take it, take that for today. Don't take more until you know how it's going to react for you, and then if you notice nothing, you can try a little bit more tomorrow, because it can take up to 3 hours to feel the effects from the edibles. That if they've got high-risk cardiovascular disease or serious mental illness, that's who I'd consider not using this. Talking about those side effects, risk of confusion, falls, and then some of those personal legal considerations. And then for the more system legal considerations, I'll let Rob take over.
Thank you. I just wanted to say that Emily and I've had a chance to present on this a couple of times the last few months. And every time I hear you speak, I learn new things and I have different memories that are triggered, no pun intended. When you mentioned glaucoma, it just brought me back to a story. I have a family in California, and I got a call from my mom in California, worried about my brother. And this is back in 2007, I think. And lo and behold, my brother had developed glaucoma. And now he had a certified card that he could buy medical pot. And she was really concerned about his health. Now, my brother at that point was in his 20s, and he was really happy to get his pot card, as he called it. But when I think about this and what triggered that is, what are the expectations that are out there? We look at the recent changes in Minnesota in the law, what's happened in the last year, what's happened in the last 5 years, 7 years, and really it is, I think, raising more questions than answers that are out there. It's setting expectations for you as the practitioner and the clinician, your patients, the team that you work with, especially in the world of long-term care, which is where I get to see a lot of this come down. But what is that expectation that's out there, right? So in Minnesota, this past March, we can now smoke medical cannabis. This is something that's been confusing for a lot of years. When medical cannabis was first approved, how many times did you hear people think, or at least share, hey, you know what? That means I can bring mom a joint. It's medical cannabis, right? I'm going to give her some of my own stash because now it's legal. Well, the answer was pretty clear back then. No, it's not. In fact, Minnesota was really strict about saying we aren't going to allow smokable forms. In March, we said, yeah, I guess we will. So, right, it's what is the expectation that's out there? And then in July, we've got edibles, and edibles are now legal statewide. And what does that mean? Well, that means, in my experience in working with providers in the last few months, that families that used to have to cross the river and go to Wisconsin to get the edibles to bring grandma are now just getting them here in Minnesota at SA or you name it, and bringing them and just dropping them off. Again, this is an expectation. So just understanding, what it is, what is the application that's out there is important for you as you're navigating this with the teams that you're working with at region sites, helping them have a better understanding as to what is going to be your practice and your policy to help your patients succeed, and certainly you as the clinicians succeed as well. So we have a lot of questions that are out there. Non-medical cannabis in Minnesota, it's out there. Emily did a really nice job explaining what that dosage is in Minnesota, which is different than what you might get in Colorado or Wisconsin or you name it. And I love the example of saying maybe you don't need the whole gummy bear, maybe you just need the foot, right? Being able to have that educated conversation with your patient and their family is really, really important. There are some pretty, standard restrictions that are here, right? So it has to be in child-proof and tamper-evident packages. It has to be clearly labeled. I wish there was a requirement that the labeling would talk about dosage, and if it was going to be something that was smokable, like inhaled versus edible, what that might be in terms of the intoxication and what that period would look like. I think that would be really helpful. I know there is a few advocates that are out there trying to make some legislative changes just to be able to tweak that, because I think that helps the consumer and then helps us as we're working with patients too. And the one that I'd like to just point out here, the last one is labeling can't take the likeness of brands of products. So it's not supposed to look like other stuff, which would fool the consumer, right? So that's the rule. What's the reality? It's confusing as all get out, right? I mean, these are legit. What does this tell the grandson who has had a lot of success in his own medical application of marijuana when he's ingested that from his stash? Now it's legal. Now we can get these edibles for grandma who's got a lot of pain. I'm going to pick up some Skittles. I'm going to drop them off with grandma. does grandma understand what she's eating, ingesting when she gets, right? I mean, it's a little wild. Oops. Thank you. Okay, so here's our reality. We do have the medical cannabis program. Emily did a nice job explaining what that is. A couple of requirements that are important for the provider to understand, because if somebody's saying that they are going to be taking medical cannabis, there are rules they have to play by, and you can request proof that they're playing by the rules if you want to. Or if you're working at a nursing home, that nursing home can ask for that proof too, which can be very helpful depending on the nursing home's policy and procedure. So they have to be diagnosed, the patient does. They have to have the certification for their practitioner to have that, confirming that diagnosis. They have to enroll in the program, and then they have to renew that, right? Those are requirements. What I have seen in working with some clients in the last few months, now that we have edibles that are legal, and some of the barriers that are out there, or I won't call them barriers, hurdles that are out there just from cost and availability of the medical cannabis, some people have opted to say, you know what, I'm gonna let that lapse because now I can get it edibles, and I'm just gonna self-treat, self-medicate. So something to think about when you're working with people. You have to have that registered designated caregiver. I am your lawyer as the clinicians, as the advocate for the practitioners, the providers. I would always recommend that this person is not you, right? If you're working with this, I see a lot of people nodding their heads. You'd be surprised when I've told people this in the past with my recommendation. They're like, really? But I think I'm the most qualified to be able to handle something. And the answer is, yeah, you probably are. But you can get yourself and your whole team in a lot of trouble if you accept any kind of federal or state dollars, right? So it shouldn't be you, but it is going to be somebody, and it's very stringent in terms of what the requirements are. So they have to go through the program, they have to be certified, they have to be 18, it has to be approved, and then it is authorized, and they've got that designation. And then they are the ones that go to the medical cannabis site, they meet with a pharmacist, which I think is fantastic, they're educated the best that they can be, and then they are the person that's going to be handling it, not you. I will just say and I'm going to mention this a little bit later too, when we're thinking about what that policy or practice might be, or questions that you and your team might be asking your patient, is who is your designated caregiver? And if it's let's say it's your adult daughter, what happens when she takes a vacation? Do you have a backup? Or she moves out of state, right? Just planting those seeds to let people know that there are other options they should be considering if they're going to participate in this. This is not you. Thank you. So, from the facility level, they have the ability to restrict access. They can. But again, that restriction isn't the access for the patient to have it, it's the access that the provider is going to have, the nursing home in this example, right? So the restrictions that the nursing home can put in there if that patient's going to participate in the program is the nursing home will not store or maintain the medical cannabis. That's going to be on the patient. The nursing home will not be responsible for providing the medical cannabis. The nursing home is not going to store the medical cannabis. That's going to be up to the patient. Now, again, the facility is statewide told that they can't restrict outright, but they can put these procedures in place to say, you know what, if you're going to participate in the program, we need to make sure that it's being done safe and it's being done in a way that's going to help everyone succeed. So those are very reasonable restrictions that I would include in a policy. So disposal, this is another issue too. So if you've heard me talk before, I usually don't give the Department of Health a whole lot of credit, but I'll give them some credit in this one. I think they've got some really good information and resources online. And I think they went a little overkill when they talk about disposal. What does disposal mean? So MDH has got a whole bunch of things that, that are out there. If you are the provider, and usually this wouldn't be you as the clinician, but it would be the long-term care facility in this example. When a resident dies or leaves, and there's medical cannabis left over, the facility is responsible for doing something with it, and they're responsible for either returning it or disposing of it. My recommendation is you return it, or your team returns it. Because if you dispose of it, and there are ways to do that, I think that complicates things a little bit. If it's not disposed of, and it just remains, that becomes an issue for the provider, because what are you doing with something on your premises that is federally illegal, and it stays there? Who's got access to it? are other vulnerable adults going to have access to that? I mean, the whole litany of questions go along with it. So policies, or things to consider for your policies. The transfer of the destruction must be recorded in the patient's health record. Why is that? And that's because medical cannabis is a property. I mean, it's actually a property right. Somebody owns that. You don't own that. The facility doesn't own it. The patient does. And so when you're returning property, that is going to be documented. When it's medical cannabis, it's required that that be recorded in the patient's health record. What's a health record? Well, the health record to me as the advocate is it's not going to be in the patient's progress notes. It's not going to be in any kind of order, because those would be things that might be looked at when CMS comes in. And CMS, wearing the federal hat, is going to say, hey, what are you doing with a controlled substance facility? What are you doing with a controlled substance physician as you're working with this facility? So what do you do? Or what does the facility do? I think that they would put in the resident's record just a notice. Notice that we did return your medical cannabis. Notice that we did dispose of the medical cannabis. And I think that that covers it. And nobody can bill for this, right? So statewide, Minnesota would say, oh, you could bill for that service. Federally, you don't want to cross that line. So if you know that your team or the facility is returning or disposing of, they better not be putting that service in for reimbursement anywhere across the line, because that can get them in trouble on the federal reimbursement side. So MDH does give some examples. How do you dispose of it? So you can bring it back to the dispensary. You can drop it off at the local cop shop. I'm sure they'd be really happy with you if you did that. Or you can take it to one of the drug take-back programs. Again, is that really feasible? Or you can throw it in the trash. And by you, I mean the team at the long-term care center. And if that's going to be done, make sure that all the PHI, protected health information, has been removed. And there's another strategy of, mixing it with things that are going to dilute it. Seems like a lot of work to me. If you can return it, that is the best practice, and I would make sure that would be in the policy. I can't work this computer. So, when I've talked to folks at the Department of Health about some of the challenges that providers are facing when we've got this dichotomy between federal and state, the response is, well, we've sanctioned this. We actually have a statute that tells providers they're going to be immune from any kind of liability if somebody was to raise a stink about this. And the answer is, yeah, in Minnesota, that's true. Here's the statute. That's not a federal protection. And when we're talking about anything Medicare related, pretty clear. When we're talking about something Medicaid related, that's a subsidized program by the feds, which is a federal program, right? So again, just knowing what the parameters are and what that playing field is helpful. On the flip side, if a facility has a good policy and procedure in place, and let's say there's a federal survey that occurs, and we've got a federal surveyor that's got I'm not going to fill in that blank, but they're just on the hunt, right? And they find out that there's medical cannabis being stored in a resident's room by the resident, and all these other things are happening, and they're going to say that's a violation. And we would turn around and we would say, well, if the policy and procedure is followed to a T, that resident has been educated on all these things, the facility asked for proof of the qualifications to participate in that program, the resident is storing this, the resident is storing it in a safe, secure location that other residents can't access, and the facility is not the one administering the medical cannabis, I think you get a get out of jail free card with the statute on the federal side, because you've done everything to say, this isn't us, that's that particular patient individually. And Minnesota has said, we have to let that happen. Does that make sense? I've heard this once come up on a federal survey where were bent out of shape about this particular issue. So I already mentioned this, and Emily did too. So, marijuana itself, cannabis, as we're, really talking about it, is that Scheduled I drug. There's also the 2018 Farm Bill, and that gave some exceptions for THC derivatives. And, it has to come from industrial hemp, for example. Minnesota law has a similar exception for that too. But at the end of the day, if we're talking about THC and we're talking about the feds, I don't think there's a bright line protecting people unless there's that clear policy and procedure saying it's not you, it's the patient, and the patient has these reasonable restrictions that they have to follow. Back in 2015, and I did check on this when Emily and I submitted our materials here a couple weeks ago, it still stands at the Department of Health. MDH's take on this is, well, statewide, it's legal. We've talked to the feds, and we don't think they're really going to prosecute you. But for me, that doesn't make me very comfortable. Now, President Biden did do something that was kind of fun to see recently, which I think is great in terms of being able to really figure out how is this going to be or isn't beneficial. But one way or the other, let's take a real look at this, which I think is very, very helpful. But again, just because this is posted on MDH's website is not just a blessing saying, yep, go ahead, let people just do it. Emily mentioned this too. I've already mentioned the first two bullets here, but the third one is the provider associations did meet with MDH and made a couple things really clear. Number one, medical cannabis is not a medication. It does not require a prescription. It does not require an order, right? Because that is where we have a distinction as to if you as a clinician are doing something that is anti-federal law, is that going to get you in some hot water? And this kind of helped that process. And the other thing is, and I see this not so much in the world of nursing homes, I see it more in the world of assisted livings and certainly home care in the community, where we have OASIS and how people are billing for certain things, or even just listing medications. Making sure that medical cannabis is not a medication so it doesn't show up on OASIS is going to be helpful. I think Emily talked about this at length as well, but Delta-9, THC, and THC derivatives share similar effects, whether they be side effects, helpful effects, you name it, right? But it's really understanding and making sure that your patient has the information that they can have, or at least access to that information, so they make the best decisions to say, is this going to be helpful for me or not helpful for me, and what are the risks? As the provider, there are some identifying requirements that are out there, right? So I mentioned that the packaging is not supposed to look like something else. It's supposed to be very distinct. It needs to be clearly identified. It's not supposed to depict images other than that particular manufacturer's logo. Go back to this Skittles thing, which is interesting, but that's not medical cannabis. We're talking medical cannabis. It needs to be labeled with the patient's information, right? Their identification number, name, date of birth. And it has to have this approval saying it right here. And I'm not going to read it, but it is very clear. And when I have looked at some of the packaging that is out there from Minnesota medical cannabis dispensaries, everything really does fit this to a T. I don't know if anybody has had a different experience, but the labeling usually is really, really clear. So what are the risk considerations for the long-term care facility? What are the risk considerations when you're working with your team, right? What if that patient has no longer doesn't have the right? They've given up the right, they've waived the right for whatever reason, they don't qualify to continue to participate in the medical cannabis program, but they still are taking medical cannabis. Or now they've switched over in that example I gave earlier, true life example, then now they're doing edibles because it's cheaper, right? That's a risk. What if your policy or the facility's policy is that they're going to request that annual verification, proof of that, and the facility forgets to do that? That can get them in trouble. When I work with clients on policies, I put it in as an option. I put it in as the facility may request written proof of your ability to participate in the program at any time. And that way the facility has some room to be nimble if they're ever pushed in that area. The patient getting the medical cannabis from somebody who's not that authorized, that designated certified rep, that's a risk. So when facilities are looking at this, they should make sure in their policy that it's really clear that if the patient is going to participate in taking medical cannabis, that it's only going to be with the right people administering that. Emily did a really nice job in terms of reconciliation with other medications and the communication with the treating, right? So I'm not a clinician, I'm not that smart, but I can't imagine what it would be like to be in your shoes and now you are working with a patient and then you discover that this patient has been taking medical cannabis or edibles or you name it, and that would have made a difference way back when if you had known, right? So putting in the policy is going to be really important, that there's going to be clear lines of communication of what a patient is doing and not doing. So as a provider, it's a big balancing act, right? So what do? We talked about the legal playing field. The reimbursement risks are out there if it's listed on anything federally. We have patient and resident rights for sure. Everyone's got a Bill of Rights. They have the right to a lot of things, including the right to access things that are legal in Minnesota. What are the expectations of your patients and their families? and their caregivers? What are the expectations of staff at a site? You know, again, I think none of this is easy, but the best place to address this is in policies, maybe handbooks, whether it be a resident handbook or an employee handbook or both. And then education is a big, big piece as well. So just some general policy considerations as I've helped clients kind of navigate this, making sure that you are going to be notified, the facility is going to be notified if they're participating, and that it's going to be legitimate participation, right? So there's some pretty standard things that are going to be here. Again, really clearly, the facility does not handle the medical cannabis. That is on the patient. And that medical cannabis has to be stored in a safe location out of the reach or access of other vulnerable adults, other residents. It's got to remain in its original packaging. The qualifying medical conditions can include, but aren't limited to, who's notifying the physician. That's that clear line of communication and making sure that that's in place. And this isn't necessarily going to be your policy, but it is helpful for you to know if there is a policy or not. And if you have a patient that's participating in medical cannabis, the medical cannabis program, asking that facility, what is your policy? What's your practice? What's your procedures? So you know what's happening or if something is happening and it ought not be. Medical cannabis is not edibles. I think that's really got to be clear, especially given what's been going on in Minnesota in the last few months. Another policy consideration for a facility is, do they allow edibles? Just because it's legal doesn't mean that the facility has to allow the edibles to be in place, right? And then who's responsible for that disposal? I think that's kind of just a big issue because it can raise a lot of questions too. So having said that, and I think I may have gone a little over time, I apologize. Do you have any questions for us?
Yeah.
When you're talking about a facility having a policy in nursing home, maybe I missed this if it's basic, but I'm sorry, but are edibles a possibility for them to even allow, or does the legal and regulatory things prohibit that?
So edibles are allowable on the state level, but not allowable on a federal level. And for a long-term care facility, and 99% of the long-term care facilities, nursing homes, boarding homes even, as we think about that in Minnesota, participate in federal programs, they can restrict the edibles for that reason.
So they could have a medical marijuana policy, or they could have an edible policy, or they could have both or neither.
Correct. Yep.
And so, one difference between edibles and like alcohol, for example, is, I'm just thinking of like, because we let patients use substances that we wouldn't generally recommend, but the difference with edibles is just that it's not federally legal. So that the facility has a little bit more ability to restrict that than maybe alcohol or.
Yep. And so you're absolutely right. So when we think of substances that are out there, there are a lot, right? Some are legal, some are not legal, some are in this area of question. In this example, alcohol is legal both on the federal and the state side, right? But edibles are only legal on the state side. So if you're a facility participating in a federal program, can you restrict the edibles but not restrict the alcohol? And the answer is yes.
I have a question on the workforce issue. So, if employees are using edibles or other things, thoughts on, drug testing policies or how that's affecting things, or a controlled substance agreement for patients, would that disqualify people from continuing with those type of things? What's been either of your practices on that?
Yep.
I can say when it comes to controlled substance agreements, working in palliative care, I have a lot of patients ask me, would trying an edible, and I just had somebody last week, one of my geriatrics patients asked me, I'm interested in trying the edibles, would that go against my opioid contract? And generally, this is something I think you should talk about with your practice. The docs I've worked with, we had said no, that medical marijuana would be allowable. There has been, there are some studies looking at, does using marijuana with opioids actually decrease how much opioids people use? Not totally clear that happens, but it doesn't look like it increases their chance of overdose. And so I think working that out with your practice, but in general, I have not dismissed people because they now have a positive marijuana. But it's something that we should know because of these interactions with all their other meds. And then as far as employee testing,
So I do practice in employment law, and I probably could talk about this for a long time, but the short answer that I would give you is, do you really want to know? I mean, so if you have, I mean, honestly, so when we think about workforce crisis and we think about frontline staff, and if you don't have a drug testing policy in place and you aren't required to have one, maybe you don't want one. Or when I work with clients about drug testing issues, I usually will say, okay, number one, let's look at what that employee is doing. Are they a direct caregiver or not? Because I think that can make a difference. Are they going to be operating machinery or not? Driving a van, you name it. And then secondly, are we going to require it across the board? Are we going to require random testing? Or are we going to require it based on a suspicion? And I would like to go with the latter, because if you require it based on a suspicion that somebody's not fulfilling their job function in some way, and then you question as to, you investigate, why aren't they doing this? And you have a suspicion that maybe this would involve use of drugs, use of a substance of some type, it could even be alcohol, right? Then you would do the test. Because if you carte blanche, here we're gonna test everybody, and somebody had edibles a couple days ago and it stays in the system for a long time, they're gonna fail the test because they had some gummies on Saturday, right? And now you've lost an employee, which puts you in this impossible situation. So I do think it's important for any practice that you're in, whether you be in a clinic, you've been a nursing home, you name it, take a look at what that policy is. If it's not a required mandatory drug test, because, and some programs you have to, right? I mean, it's required to participate in whatever that federal piece would be, so you have to drug test everybody that'd be doing it. Okay, you've got that. But if you have some ability to be flexible, this is the time to really examine that and say, let's be flexible. If you have a policy that's been in place just because it's been there for the last 10 years, you can take a look at that and say, does this really fit our needs right now? And why did we have it in the first place? Probably for patient safety, but are we really going to be diminishing patient safety by saying we're not going to make it mandatory? It's just going to be based on suspicion. And I think the latter would say you're looking out for your patients. Yeah.
So maybe one question on the edible, and that leads to documentation. So if I maybe come across a patient who's using edible and it's not documented anywhere, do I document it or do I just notify the facility? That's my first question. And the second one is on maybe alcohol use in facilities where they requested me to give orders for people to use alcohol. I've never understood that policy because I feel like people should make a decision with their families if they want to use alcohol recreationally, but they always would ask providers to give orders, and I'm always confused with that because I don't feel like I should be making a decision for someone to use alcohol if I don't believe in it, or maybe, but I think it's a decision that should be taken with the patient and the family, but they always want orders from provider. So since I have the opportunity to ask that question, I was wondering if you can help with that.
Right. Yeah, I'll get to this, yeah.
so this has actually come up when we've talked about this before. For the federal, the should we document it is a place that we're going to differ, because I would say best practice from the healthcare facility is that it should be in the medication list and we should know if they're using medical. That could put you in federal trouble. So that's going to be a place that I don't think we're going to have a unified answer there. I put on the side of documenting if they're using, so I know. And I know, like, in our hospital system, in our EPIC, we can document medical cannabis. But this is one of those, there's probably not a good answer right now.
Yeah, I agree with that. I mean, as the lawyer, the non-clinician, I appreciate that Minnesota agreed that we would not include medical cannabis as a quote-unquote medication for that very reason. I also think it is super important that the physician understands what's going on with their patient. And so even if it doesn't end up on a medication list, if it can end up somewhere else in that resident's record, that patient's record, so you as the clinician know what's going on, I think that that's important. Now, when we talk about EMR, right, the electronic health record, what does that look like? Not every record speaks to other records, right? So it might be documented at one site and not somewhere else where you're going to be readily finding that. So this is a big challenge. As the lawyer, though, protecting you versus protecting the patient, I would say don't include it on the medication list. My physician, if I were in the program, I'd really want them to know. I would. And I wouldn't care if it showed up on a medication list or somewhere else, because I'd want them to know about me as a whole being, right? To your other, I think you had three questions. Your second question, working backwards, though, Why do facilities reach out to the physician and ask for an order on this or that when really this wouldn't be based on an order? It's a personal decision, right? And I think as the clinician, you have to be able to push back a little bit and say, you know what, I don't think it's appropriate. When I've worked with clients and saying, well, let's get an order saying, alcohol use is appropriate, I think that's kind of silly. But I think it's really important that if alcohol is being abused and it's been really, really harsh on that particular resident and the resident's going to continue to do things, and we can get a physician to chime in and say, you know what, we would recommend that the patient not drink alcohol, not, whatever that's going to be, and have that recorded. That's not an order, but it does show that the facility is doing what they can from a whole, person-centered approach to say what is going to be best for that particular resident. So I think as the clinician, when you're asked to do this order, it puts you in a tough spot. People ask you for orders all the time. I know that they do. And you can say, you know what, I don't think it's appropriate for an order, but I'm willing to have a conversation about it because we want to make sure what's going on with this Rob the resident, right? And now I've forgotten your first question.
Well, and I would say,
Yeah.
as the clinician, I think a lot comes down to, I'm sure a lot of us work in multiple facilities, is what is your facility's policy on this? And I think there is a difference between someone who's having problem drinking and their family brought them a bottle of wine. Can I have an order? And so what I have done is if their policy is they need an order, I have done it within what would be medically acceptable. So a woman can have 1 serving a day, a man can have 1 to 2 servings, and that's what I would give them an order for. But that's how I've done it. And I think asking your facility, what is your written policy on this, so I know I'm following that policy.
I just have a question, so, regarding like how we would document as providers, our recommendations for the clients that we work with. Say they wanna use CBD topical lotion, like topical creams, say they wanna use these CBD gummies, say they wanna use these THC gummies. We're all federally at risk as providers, but through the state of Minnesota, we're not. So how do we choose to document in the assessment and plan versus not including in the medication list versus including in the HPI?
If I'm having that discussion, I'm documenting it in the progress note with the same caveats that I discussed, the risks of falls and confusion. But given their chronic pain, I think a trial of CBD is reasonable.
So you may include your recommendation that they do go forward with that certain treatment in your notes.
The way I would put it is I would say I informs them of the risks and benefits and that I think this is a reasonable trial.
Okay.
Yeah.
What does that relationship look like with the practitioner and the pharmacist? Because it almost sounded like we give the order, but the pharmacist, the designated pharmacist is the
yeah.
person that's managing it?
I can tell you there's, at least from the probably 40 patients that I've certified, I hear nothing back other than a evaluation once a year of what do you think of this program. So all I know is from what my patients have told me when they go, and I've actually had a patient bring me the menu, kind of the list of what they had, and I was like, this is so helpful because I have no idea. So no, my role is I can say that I think this is reasonable for you, and that you do have a condition, and that I'm going to keep seeing you. So, and then they have that in there, so this isn't a one-off cannabis visit, and you don't have, these cannabis approval clinics popping up. But so your role as the clinician is really to say, yes, you have a certifying condition, that I'm your clinician that knows you, that's treating you for this condition, and that cannabis is reasonable. And then the rest of it's handled by the cannabis program and the dispensary.
It sounds like we're attached to like all whatever is prescribed, right? Like the dosage, but there's not a lot of communication.
We're really not attached to the dosage at all.
We're just saying, we certify you, we believe
Yes.
that you have this condition.
Yeah, I'm giving you the clearance that medically this is reasonable and you have this condition. Anything about the dosing, how often they use, that's all done through the dispensary, and I don't comment on that unless they're having side effects. But it is, as part of your ongoing relationship, I do think it's good to ask, are you using this? Are you not? Is it helping you? Because that may be affecting, well, do I try this other line nausea medicine? or what am I doing with their pain medicine? So I do think it's helpful to know, but I don't know the details of what they're getting.
All right, I'm going to take that and just take that into the question I didn't answer yet because I remembered it. The question you had asked was, if you see edibles in a patient's room, do you need to tell the facility, do you need to document that, just like you would or wouldn't do with like a bottle of alcohol? And I think you would treat it just like you would a bottle of alcohol. So you might inform the facility, hey, I noticed that Rob had a bottle of whiskey or he had some edibles on his night table, and let them know. But going to what Emily just said too, I think as the clinician, you have that responsibility to ask some more questions of your patient saying, hey, I noticed some edibles. Are you taking these? Are these yours? And then just really learning more. And then based on what you learn from that dialogue, documenting that in some form. It might not be certainly in an order or anything like that, but it would show up that you as the clinician are paying attention to your patient, if that makes sense.
So, yeah, so.
I'm sorry to interrupt,
Yeah.
my lunch is ready to go.
I was just about to say.
We'll wrap up in the next couple minutes.
Yeah, we'll be up here and you're welcome to ask questions, but we'll go ahead and let everybody have lunch. Thank you all.
Thank you all very much.